we will be moving on to our next session, which is a panel discussion on vertigo. For this session, I would like to invite on stage the chairperson for this session, Dr. Koustubh Chakraborty, consultant physiatrist, Peerless Hospital.
Let me invite the esteemed panelist, Dr. M.N. Bhattacharya, senior consultant otorhinolaryngologist at Peerless Hospital, Kolkata. Dr. Madhusri Sengupta, consultant physiatrist at NH Rabindranath Tagore Hospitals, Kolkata, and Dr. Tirthankar Dasgupta, consultant psychiatrist. In our practice, and I'm sure in all general practice, vertigo is a common complaint. Can be a true vertigo, can be some dizziness. So just to delve into that, we have kept this session, and I'd like to start the proceedings with Dr. Madhusri Sengupta, that what are the causes of vertigo that you come across in your clinical practice, and how commonly do you feel that patients with vertigo are referred to rehab?
Good morning to everyone. I think I have to divide it in two divisions. One, when patients are coming with some complaints, and second, when they are referred from other consultants. So when patients come with complaints, I think commonly I get BPPV, orthostatic hypotension, and other causes that need to be evaluated. But when they are referred, I primarily get the neurological causes. I get migraine, Parkinson's disease or Parkinson's plus, a good number, stroke, or maybe a neuroma, brain tumor. So these are the common causes that are referred to me. So if it's a neurological cause, it's quite commonly referred. If it's a non-neurological cause, no, often it is not referred to me.
Okay, thank you. Dr. M.N. Bhattacharya, so those cases of vertigo who are going to the ENT clinic, again directly or being referred, so what are the common causes that you find in your practice, and approximate percentages of patients with each cause?
Thank you for having me here. Most commonly we see, as we all know, BPPV is the most common cause. Apart from that, we see loads of patients with vestibular neuronitis also, even vertiginous migraine, and also menias we see a lot, which are either undiagnosed or underdiagnosed. So menias, there is a good number, but according to literature and all, it's about 1%, near to 1%, but again, with a population of 140 crore, so 1% is a lot, and so we see a lot of menias also. But most commonly, yes, BPPV, and other causes are there, but they are not that common.
Thank you. Dr. Tirthankar Dasgupta, sometimes we come across cases where anxiety is the cause. So how does anxiety cause dizziness and vertigo?
Thank you so much for having me here. Anxiety is I find in our practice is a very common cause of dizziness. Basically, the idea is what causes anxiety, the external trigger factors, what the internal mechanism is. In a one or two line, I'm trying to discuss with the August gathering, that basically the stressors come from the outside world. They cause in the vulnerable population the excitement, overexcitement of the amygdala, which actually is the threat perception main center, and that triggers the overall threat detection system of inside the brain. There are other two parts which we need to know, which also causes this anxiety. One is the insula, which actually detects the bodily sensation. When the insula, the threshold level is lowered down, they just detect the internal stressors or the variability of the body parameters much before than we all in the normal situation. And the final part is in the prefrontal area, there is an anterior cingulate cortex, ACC, that analyzes which signal we need to think about and which signal we need to reject. That particular thing completely hijacks during the anxiety situation. That triggers the autonomic system, hyperarousal, the vasoconstriction, and because of this vasoconstriction, what happens in the vestibular system, the vasoconstriction, because of this vasoconstriction, they also just not functions normally. This is one issue. Another, because of the hyperventilation, respiratory alkalosis, and for that, again, that vestibular system gets disturbed. So altogether, the so-called functional is not functional. They are leading all these, symptoms and finally leading to this vertigo.
Okay. Thank you so much. Dr. Sengupta, what are the clinical tests and diagnostic tests you do to differentiate between the causes of vertigo that present to your OPD?
See, no matter what the cause is, I try to go for a detailed examination first, because often patients come with a symptom saying that I have vertigo because I'm a spondylosis ache, which may not be the cause in the first place. So to find the symptom, sometimes we need to find the sign. So a thorough neurological examination, a baseline psychological assessment, and to the physical examination, especially to see if there is any nystagmus, any Romberg sign, any gait disturbances, any stressor factor. Like Dr. Tirthankar said, that it is common that the functional aspect that you're saying, that also has an organic basis. So it is often overlooked. No matter what the cause is, a trigger, psychological trigger, can change the rehabilitation outcome. So I do look into that. Apart from the detailed neurological examination, yes, there are other tests like Dix-Hallpike and all. Frankly, I don't do them very frequently. It can be an intimidating test, and sometimes nausea happens. And there are a panel of investigations which I'm sure the ENT surgeons, they do more frequently, like EOGs and VNGs. I don't do them in the chamber, but I do guide. And there are times when I ask for scans, CT scan or MRI of the brain, when I do find something like a cerebellar signs or let's say an ataxia that I'm seeing. So I do try to do this. So detailed history and trying to find the symptom rather than going by what the patient says is very important in vertigo, unlike other symptoms.
Thank you. Dr. Bhattacharya, what are the special tests that you do to diagnose otogenic causes of vertigo?
First of all, as my esteemed colleague has said, I'll go with that only, that vertigo is such a subject. 70%, yes, 70% of diagnosis can be done by a thorough and detailed history taking. Clinical examination adds up to it. We can diagnose with clinical examination to another 15% can be added. So 80 to 85% doesn't need any investigation, honestly speaking. If any investigations are needed, that would be directed by what we are thinking of. Audiometry, tympanometry are some basic things. Clinically, what we do, I am not taking into account as an investigation. But when we think of, say, if we are thinking of BPPV, we are not doing any investigation, to be very honest. We are not doing any investigation. It's a clinical finding. If we think of Meniere's disease, then yes, audiology, sometimes we do an MRI. We do an MRI just to rule out few other causes. That's number one. And number two, in Meniere's, most of the time there is unilateral hearing loss because 80% of people are having unilateral Meniere's. So it's unilateral hearing loss. So just to rule out if the person is having acoustic neuroma or not, or any other causes, central causes which can be missed if we don't do an MRI, then only we do the MRI. There are other plethora of tests like the VNG, the ECOG, the VEMS and all. These tests are there and they are guided by, we are guided to do the test by what we can clinically think of the person is having.
Thank you so much, Dr. Bhattacharya. Dr. Tirthankar Dasgupta, how do you diagnose a cause of psychogenic vertigo?
There are certain pointers which lead to the diagnosis of psychogenic vertigo. First point is it should be episodic. Typically, generally, I don't think you get all the so-called organic vertigo in an episodic manner. This is one issue. Another issue is should be triggered by some external factors. Anything, external factors, there are millions of external factors. For a particular person, something may be stress. For another person, that may not be a stress. So that is one issue. Whenever that stressors goes away, the vertigo also goes away. That's another issue. And it has some dramatic onset. So this is, the presentation is so much of dramatic. that also leads to the suspicions that it might be a psychogenic vertigo.
Thank you. Coming back to Dr. Madhusri Sengupta, how does rehabilitation help in vertigo?
Rehabilitation.
Yes.
Rehabilitation is very essential in the management of vertigo, no matter what the cause is. Because if I look into a peripheral vertigo, long-term medications, please correct me if I'm wrong, sir, is anyway not recommended. And if it's a central cause, along with whatever the primary treatment is, there has to be a rehab program, and unless that symptoms are subsided, patient will never progress to the next step of rehabilitation. If there's a persistent discomfort, dizziness, they are not going to progress to the first step. So rehabilitation is important. As soon as the symptoms are subsided, whether that is with antiemetic drugs or vestibular sedatives or whatever, after that, we start off with a basic exercise program, which is focused on habituation, So the basic idea is we have to get the patient adjusted to more and more stimulus. And once the patient is ready, then you can move the patient ahead. So rehab is very essential. You can use, now technologies are used, exercise regimes are used, medicine has a certain role. Again, everything comes down to what the diagnosis is, gait evaluation, gait training. So rehab is a very core area in the management, relaxation techniques, etc. For whatever the cause is. It will add to the overall outcome. So yes, it is very important.
Thank you. Dr. Bhattacharya, what are the medications you advise in Meniere's disease?
Hello. It's a very good and interesting question, because Meniere's disease is such a disease till now. Why it's being caused is yet a Pandora's box. We don't know. We know that Meniere's disease, what happens, that there is excess of endolymph in that area where it's supposed to be. But why it happens, the autoimmune is said to be one of the causes, but it's said to be. All these are hypotheses. Now, anyway, in Meniere's disease, we know that the fluid has gone up. And those are the times when the person starts having these episodes. Meniere's disease, again, we divide into, we classify Meniere's as probable Meniere's, possible Meniere's, and then it's a definitive Meniere's. Definitive Meniere's only can be diagnosed once the post-mortem of the temporal bone is done. So that's after the person passes away. But apart from that, probable and possible Meniere's disease is said to be with those three pillars of Meniere's, where there is tinnitus, diminished hearing and vertigo. How many of these three are there? We say it to be probable and possible. Having said that, the first thing about Meniere's are we go for some dietary restrictions, because we find that few of the diets might increase or trigger increase in that fluid. So like caffeine, cocoa, MAO inhibitors, salt in the diet, some says that even nicotine and spirits, they also can cause. So these are the dietary restrictions we go for. Number two is if the person is really having episodes of severe vertigo, then just to calm down that effect, labyrinthine sedatives are given, but again, that's not a regular basis. Once the symptoms gets better, we stop that. Otherwise, compensation, what she has said, compensation becomes a problem. And addressing to decrease in the symptoms, decrease in the fluid being accumulated, we give histamine analogs like beta histine, which works in many ways with dilatation of the smaller blood vessels so that they can absorb the fluid from there. And also antihistamines we add to. Antihistamines are said to be some of the drugs which can actually give lesser amount of fluid accumulation. Apart from that, diuretics in some cases we add to it. So these are the, if you talk about the medical aspect, these are the medical or the pharmacotherapy we start with. But again, Meniere's is something which we treat in a step ladder fashion. So once we restrict the disease, I'm not saying curing the disease. Once we restrict the disease at a certain level, we then stop and maintain that. But if the disease come back or it escalates, then that step ladder fashion of treatment gets escalated.
Thank you so much for that detailed explanation. So, Dr. Dasgupta, how do selective serotonin reuptake inhibitors help in dizziness?
Yes, sir. Fantastic question. Selective serotonin reuptake inhibitors like escitalopram, paroxetine, they help in dizziness, but the duration of dizziness is also important. If the patient complains of this kind of psychogenic dizziness for a quite prolonged period, then this SSRI we think of, and that can have a good role to play, because they basically nudge the serotonergic system of the brain, by which that I was talking in the first answer, that they just reduce, they just increase the threshold of this, of those all area, amygdala and whatever. And finally, generally this psychogenic vertigo patient, they have the tendency to over-ruminate, overthink about that same thing, anxiety, the dizziness, I'm suffering from dizziness, all these things. See, this rumination actually activates the default mode network of our brain. Serotonergic system, if I nudge it and if I increase the level of this serotonin, this default mode network overactivity gets reduced and the homeostasis is established. The patient then complains, the complaint is gone. So in that way it is okay. But in the first visit itself, patient complaining about just 2 days of vertigo, and all the investigations, the organic part, so-called organic part. Again, I don't believe in this non-organic concept. So that is, resolved. Then you immediately don't start this escitalopram or paroxetine. You just observe with the rehabilitation, neuro-rehabilitation and all these things. If it goes away, then okay. If it doesn't go away and patient continuously complaining about the same thing, presentation is same, dramatic, very nagging, very ruminating, then you have to think about adding this escitalopram or paroxetine SSRI.
Thank you so much. So, Dr. Sengupta, you mentioned as BPPV being one of the principal diagnoses in the PMR OPD. So, what is your treatment approach to BPPV?
Thank you. If it's a diagnosed case of BPPV, even then I do not skip on the clinical examination like I said, and the baseline psychological status of the person, take help of my colleagues if necessary. So I start with pharmacological management to subside the acute episode and simultaneously start a rehab program. But the rehab program intensity that gradually increases. On day one itself, it can't be a very high intensity, high frequency exercises. Also, BPPV is one thing that affects the quality of life of patients. So we need to address those things as physiatrists too. So I do commonly go to the Cooksey-Cawthorne group of exercises, Brandar of exercises. So the basic idea behind these exercises is that you're habituating the patient and adapting, helping the patient to adapt. So you start with the eye movement, head movement, shoulder movement, and gradually the entire body, sit to stand, stand to sit. So you keep giving stimulus to the patient. For example, you look at the finger. Without moving the head, just move the eye. Now move the head as well. So gradually you adapt the patient and make it tougher. Tougher by giving more stimulus, tougher by changing the angle of the stimulus, tougher by increasing the frequency. It is very important in BPPV rehabilitation to go slow, because I have seen a lot of patients, they get frustrated because in 1 or 2 days, if you're giving a high intensity, their symptoms recur and then they don't want to do anything. Simultaneously, I do guide them regarding simple lifestyle modifications as well. If it's a stressor, how to deal with it, maybe relaxation techniques, cognitive behavior therapy, or visiting a mental health professional might help. Or when you get up from the bed, suddenly you don't stand up, or when you're lying in bed and suddenly you turn and there might be a change and you might have an episode. So these simple guidance, don't extend your neck too much, don't bend too forward. So gradually adapt the patient to so that you get the patient back to his or her good quality life. That is how I approach. Of course, there are deviations if they have something added to that, some other organic cause which needs to be taken care of. But this would be the basic guideline. Pharmacology, exercise, graded exercises, lifestyle modification, improve functionality quality, use technology where you can.
Okay. Thank you, Dr. Bhattacharya. Despite these approaches, some patients might be having a recurrent BPPV or a refractory BPPV. So in these cases, how do you manage the patient?
BPPV is such a topic where we need to understand why it's happening. It's mostly because of displacement of the otoliths. That's that's the cause of BPPV. So once we diagnose a case of BPPV, the next thing we would do is that no head movement should be done to that patient apart from targeting the exercise or the procedure which brings those otoliths back to its position. So in the clinic we can do Apley's maneuver, but if we don't want to do it in the clinic, we want to give the patient something to work with, because if the patient gets involved, then the psychological component also gets cut off. That we have seen, that he or she gets involved in his or her treatment process. So some exercises like Brandorf exercise are given to the patients, or Simmons maneuver, whatever. So these are given to the patients. The main idea being that those particles goes back to their normal position. Now when you talk about refractory cases happens, then you need to think that are there a second cause of this vertigo also? Because with menias, there can be BPPV. If you are looking only at the BPPV component, or vestibular neuritis can have also BPPV. So are we targeting all the causes of the person's vertigo or not? That's one of the causes of refractory. Sometimes in BPPV what happens is all those particles doesn't go back to its normal position. Then also the patient can have this thing. So this maneuver needs to be done again. So that's one of the cause. Central cause needs to be looked after. Anxiety or psychological factor needs to be addressed. And for some days, again, not for a long duration, for some days, a bit of labyrinthine sedative to calm down the effect also helps. So these are how we look into it.
Thank you so much. We have discussed BPPV. Now I want to ask Dr. Tirthankar Dasgupta, what is PPPD, persistent postural perceptual dizziness?
Yes, this term was coined by, if I'm not wrong, Barani Society, the PPPD. Sir might confirm. So its persistence means it should stay for quite a long time, according to the guideline, 3 months and above. So at least for 3 months, this dizziness should stay first. Then perceptual. Overall, as I was talking about those two or three structures, the perceptual threshold gets lowered down. So body detects all the abnormal signals from the environment and the inside the body quite early than we used to pick up. They think that I am in a very dizzy feel, I am in a rocking boat like kind of thing. Perceptual. And this, this postural. So generally this patient complain of this dizziness, dizzy feeling in the upright position. Almost like BPPV is not exactly BPPV. This is one thing, and dizziness. So this is basically non-reeling, non-spinning kind of vertigo. They complain of this rocking boat sensation, this dizzy feeling throughout the day, almost throughout the day. Not like typical anxiety-induced dizziness, reeling or vertigo, where it goes away, comes and goes. It's not like that. It's the graph is almost static for the 3 months or above. So this is PPPD.
Okay. Thank you so much, sir. Dr. Madhusri Sen-Gupta, so how do you integrate the traditional rehab approaches and advanced technology towards vertigo management, of course, based on the etiology?
The beauty of rehab is you have technology in your hand and you can explore that. So COVID has probably, given us exposure to what telemedicine is. So BPPV is one of those conditions which can be handled through telemedicine to a certain extent, of course, with all the ethical concerns that we discussed earlier. If I look into further, what extra can I do over and above what I have mentioned? See, nothing replaces a good rehabilitation program and hands of the doctor or the therapist. Along with that, as an add-on, you can use further technology like virtual reality. It's excellent in management of in vestibular rehabilitation. You can increase the stimulus, you can change the stimulus, you can play along with it. Excellent. If your clinic has a TRV chair, it's a bit scary, but the chair suddenly goes up and down. So if it's a saccule, it'll go up and down. If it's the utricle, it'll go horizontally, sidewise. If nothing, you can have a rocking chair, which you can, place it in a certain direction. And these things can be automated and helps in vestibular rehabilitation. AI, of course, nothing is untouched by AI in today's world. Robotics is being used. So these would be the advanced technology. If not anything, you can also guide patients to have smartphone-based apps. These apps can also diagnose your postural problems, your, whether your vitals are stable or not, and your orthostatic hypertension you're having. So these things. So simple apps on the phone, exercises, and when you can use technology, use it. And even you don't need very elaborate technology these days. Everything can be customized to fit into your laptop or in your home. So if a certain amount of expense is not a big deal, then definitely higher technologies can be used for rehabilitation of all kind of vestibular dysfunction.
Thank you, Dr. Sen-Gupta. My next question is to Dr. M.N. Bhattacharya. What is vertiginous migraine that you had mentioned, and how do you manage it?
Vertiginous migraine is sometimes it's said that migraine can manifest as vertigo, or a person who is having migraine since long can have an effect on the vestibular system with vertigo. Now, vertiginous migraines, the signs and symptoms, it can mimic that of migraine in the sense that there can be some triggering factors. There can be, the duration again can be for hours. It can be associated with nausea and vomiting because it's being triggered with the vestibule. And as I've said, that certain stimulus, it can be emotional stimulus, it can be physical stimulus like screens, and also it can be vertiginous migraine. Again, during an acute episode, labyrinthine sedative needs to be given to calm down, but again for a few days, or just so that the compensation takes into account. And number two is there is a plethora of medications which we give. Even the migrainous, anti-migrainous medications, calcium channel blockers, even the NSAIDs, they sometimes help. So these are what it is given or advised to the patient. One thing I need to tell about vertigo is, like our previous learned speaker has said on the ethical aspect, there one point was raised, that communication with the patient. I don't know whether how many of us has suffered from vertigo. I think all of us, maybe for few seconds, but in a lifetime, all of us suffers from vertigo. Vertigo, the experience is a bit scary. For layman's, like non-medical person I'm talking about, once they suffer this scary experience, they think about a lot what's going on. So when it comes to vertigo, we need to, first of all, I have seen that helps, console the patient once the diagnosis is done, that what the patient is actually suffering. It's not a life-threatening or life-taking away symptom. So that needs to be told to the patient. Half the job is done with that. So we need to communicate with the patient regarding what is happening and why he or she is having this symptom of vertigo.
Thank you so much, sir. And Dr. Dasgupta, I'll ask this question in two parts. First, what's the management of persistent postural perceptual dizziness? And second, is there any role of benzodiazepines in your practice for management of vertigo?
Okay. So coming to the first question, triple PD, the management of it is basically number one is neuro rehabilitation. Without neuro rehabilitation you cannot do, because we often find those patients have a lot of stiffness, lot of body stiffness, neck muscle stiffness and all this stiffness and all other issues which has to be addressed by rehabilitation programs. So this is mandatory primarily. Second, I find useful is either SSRI or SNRI, like venlafaxine, duloxetine or desvenlafaxine, depending on the case. That also varies person to person, which particular medicine will suit, that you cannot decide just at the first visit sometimes based on the past history or something you have to understand. This is one issue. Basically you have to depend on the pharmacotherapy as well as the rehabilitation. And also, as sir was saying, that is very important. The problem is not life-threatening, this counseling, the initial reassurance, because these, whether it is so-called quote-unquote organic or non-organic doesn't matter, it actually gives rise to too much of sympathetic overactivity. So they all have the hyperventilation, trembling of hand and all this sweating, nervousness, everything. So tone is very high, sympathetic. So just to lower it down and then to increase the parasympathetic tone, you have to advise for the breathing maneuver, breathing technique, reassurance, calming it down. So basically you are maneuvering the patient by your talk and your whatever gestures, non-verbal gestures, communications you are doing. This is the first part. So far as the second part is concerned, is very, very debatable. The question and the answer is very debatable, because there are a lot of discussions going on in other fora also about the use of benzodiazepine. And it is such a drug. All our patients, we find that once they adapt it, they goes on taking these benzos. So we are basically responsible for this quote-unquote so-called addiction of benzodiazepine. Who is the prone to addiction will take this benzodiazepine. But the selection is important. We won't do it in the elderly patients, first point, because of the problem of falls and all these things. So fall is a very common problem in elderly, as you all know. And also in the cases where there is a organic basis, basically the brain tumor or Meniere's or BPPV or all this kind of thing, we don't give it for the prolonged period. Yes, for the short term duration definitely is useful to reduce the initial extreme anxiety. So you have to reduce that extreme anxiety for a very short period, then it is useful and it gives the instant one-shot result. So it's almost like a rescue drug, but for the long-term stability, never. Long-term stability, always you have to rely on those, the molecules which give rise to the stability, brain stability, like SSRI, SNRI, all this. SSRI, SNRI is basically, they are the stability drug. So even for throughout the life you also can take. So no issue, depending on the case. But benzo, never. But ultimately at the end of the day, patient goes on taking. If you write in the prescription stop, still they procure it from the pharmacy and chemist shop and they goes on taking it. So
thank you so much. So an otorhinolaryngologist, a psychiatrist and a physiatrist have given us a very good insight into the common causes of vertigo and their management. So with this, I'd like to conclude the session. Thank you very much, esteemed panelists, for your valuable insights. Okay.